Thermoregulation is the baby's ability to maintain their body temperature after birth. Babies are born with brown fat, which is used to regulate body temperature. An infant does not shiver to raise his body temperature, but yet the baby will burn the brown fat instead. It will protect them from hypothermia. If too much brown fat is used, then the baby can become into metabolic acidosis. So at this point, you will see too much heat loss, too much brown fat burned, which leads to cold stress, which is signs and symptoms that the baby has developed burned too much brown fat. As a nurse, we will help prevent this heat loss, and we will teach our parents how to prevent heat loss in the newborn. There are 4 different ways the newborn can lose heat. The first one is conduction. And conduction is a transfer of heat from the infant's body to cooler surfaces, like towels or a scale or the bassinet. So we will pre-warm the warmer before we place the baby on it right after delivery. Pre-warm towels, pre-warm blankets. So we will not place the baby on cold surfaces. The next one for B is convection. Convection is a transfer of the body heat to the surrounding cool air. And that can be from a breeze, from the air conditioning in the room. It could be from the ceiling fan. So we will prevent heat loss by keeping baby away from drafts. The next one is evaporation. Evaporation is a loss of heat from being wet. So we want to make sure we keep baby dry. Radiation is a transfer of the infant's body heat from a cold object that it's not in contact with, such as a window. So the window is cold and it will pull the heat towards it. So we want to keep the baby away from cold things that are near it, so away from cold windows. Now, in order for the baby to produce heat, the baby will metabolize the brown fat. And we also call this non-shivering thermogenesis. So when the baby starts to have a drop in body temperature, it burns the fat, but the baby's not going to shiver. If the brown fat reserves can be quickly depleted if the newborn experiences prolonged cold stress. So when this happens, the brown fat breaks down into fatty acids, which can lead to metabolic acidosis in the newborn. Newborns can also attempt to raise their body temperature by crying and kicking and can become quickly fatigued from this effort. The prevention of cold stress in a newborn is a high priority for the nurse. As the infant tries to regulate body temperature, an increase in metabolic rate occurs. The consequences of an increased metabolic rate from the cold newborn is an increased need for oxygen, decrease in surfactant production, an increase in the use of glycogen storage, which can lead to hypoglycemia, and a rapid metabolism of the brown fat, which can eventually lead to metabolic acidosis. The infant who has developed a low temperature related to cold stress will probably have some signs and symptoms of respiratory distress. They will need to be put underneath a radiant warmer to bring their temperature back up. They'll need to be on a monitor to monitor for respiratory distress, and they will also need blood sugar checks to check for hypoglycemia. Let's look at neonatal hypoglycemia. This is defined as when the blood glucose level falls below or equal to 50 milligrams per deciliter. Some risk factors for neonatal hypoglycemia include fetal distress during delivery, maternal diabetes, medications that mom might be taking that affect her blood sugar, prolonged labor or any other infections during delivery, respiratory distress and cold stress, preterm infants and low birth weight, or post-term babies who are large for gestational age. Signs and symptoms of hypoglycemia in the newborn include jitteriness, poor feeding, listlessness and irritability, low body temperature, a weak or high-pitched cry, and hypotonia. For late signs and symptoms is respiratory distress, apnea. Apnea is not breathing for longer than 20 seconds or more. Seizures or coma. Let's take a look at what the nurse does during the initial newborn transition assessment phase. We will immediately dry the baby off with towels, and that will stimulate crying. We want the baby to cry because as a nurse, we're looking to see if the infant is transitioning into extrauterine life well. We want that cardiopulmonary transition to happen. We want an initial respiratory rate over 30, a heart rate over 100. We want the baby to have that pink color after vigorous crying, and we'll get an initial vital signs. Remember that the initial assessment for the newborn happens by the RN. This can all be assessed on mom's chest. So directly after delivery, after the head comes out, the mouth and nose is bulb suctioned, then the baby is born, and then they put the baby on mom's chest, and they reduce skin to skin while the nurse dries and stimulates the baby off on mom's chest for skin to skin, as long as the baby is beginning to make a respiratory effort and vigorous crying. However, if the baby is not having vigorous crying after stimulating with the towels, you will remove the baby from mom's chest and put it under the pre-warmed radiant warmer, where you will further assess the baby and attempt to help the baby breathe. In the background, when the baby is being born, there's someone at the warmer has a timer, and they're pressing the timer as soon as the baby is born. So at that 1 minute mark, it will beep, and then we will do the APGAR scoring at that time. We'll score the APGAR system at 1 minute and again at 5 minutes. So this is done by the RN. So you look at A for appearance, the skin color, P for pulse, G for grimace, A for activity or muscle tone, and then R is respiratory rate or respiratory effort. And for the nursery nurse has all this memorized. So in order to know how to look at the chart and do this, we know what normal looks like. They should be pink and bright and a heart rate that is over 100 and good. They should be jerking back whenever you pop their feet. That's their reflexes. And activity, they should be active and crying and flexed and highly stimulated at this time and have a vigorous cry. So whenever something is missing, we can know what's missing and just deduct a point for everything that's missing. Most of the time it's just for color, like they'll have acrocyanosis where their hands and feet are blue but their body is pink and they're breathing fine. And then if their pulse is not 100, then, well, is it below 100? Minus 1 point. Is it absent? Minus 2 points. So that's how they can come up with the APGAR scoring very quickly. Scores that are between 7 and 10 are pretty much normal. Anything that's less than 7 is going to require significant help, whether it's being intubated, transferred to the nursery, giving extra oxygen. They're going to need something done, whether it's resuscitation. Anything that's 3 or below is very severe distress, and they're probably being resuscitated at that point because their heart rate's going to be less than 100, and they're not going to have a lot of effort, so they're needing a lot of help. We'll look at vital signs now. Routinely right after delivery. After the APGARs are done, it's going to be every 30 minutes for the first 2 hours of life, then whatever the hospital policy is after that. So every 30 minutes for the first 2 hours, and then where I have had experience was another 1 every hour for 2 more hours, and then you're going to check the temperature every 30 minutes until it's stable. So we want our temperature to be greater than 97.6, okay? We want our heart rate to be 110 to 160. The respiratory rate should be 30 to 60. So with the APGARs, make sure you know the 5 things that the APGAR measures: skin color, appearance, pulse, heart rate, reflexes, muscle tone, and respiratory effort. Let's talk a moment about newborn safety, because immediately after the baby is born, before that baby leaves the room ever, we have to have some safety things in place. And the most common method that is used is armbands. So there will be armbands that are placed on the baby, the partner, and mom that all match. All 3 will match. And we have to educate mom when we put this on. So some of this education starts early and it continues on throughout their whole hospital stay. So every time we bring the baby back to you after it's spent time outside of your room, the armbands are checked, for their medical record number, birthday, and whatever it says. So it must match. Newborns all start to look alike after a while, and we don't want to accidentally bring back the wrong baby. So we have to check and double check. We also will check the armband before any procedures are done on a baby with the chart and orders to make sure we have the right baby with us that we're going to give medications to or whatnot. We'll also install an alarm tag that will go on the baby's leg, and it'll be tight and snug, and anytime that the baby goes near a doorway, it will alarm. Since this is the same time period, we'll most likely get the newborn medications. Usually they're given within the first 2 hours of life. The first one is vitamin K injection. It's given IM in the vastus lateralis muscle of the baby's leg. And this is given because the GI tract in the baby is sterile, and it's the GI tract where vitamin K is stimulated through the liver to produce, and the baby's liver is immature at this time, and the GI tract is sterile. So we give the vitamin K IM, and we need this for clotting purposes. The next one is hepatitis B vaccine. We make sure that the consent form has been signed by the parents for hepatitis B. Hepatitis B vaccine is given to prevent severe liver damage and failure if the baby should ever contract hepatitis B from an unknown status from the mom during delivery. So the next one is erythromycin ointment, and this goes in the eyes, and you instill it in the lower canthus of the eye. And this is to prevent any infections that the baby could have come in contact with during delivery that could cause blindness. The one that we are especially concerned with is chlamydia, and we want to make sure that there's no infections that could develop in the eye.